lot, Dr. Vanashri, for having me in this very interesting course regarding toric IOL, and I'll be talking about the preoperative planning and axis marking and placement. I don't have any financial interest. As you all know, that a lot of patients, about one fourth of patients, they do have significant astigmatism, and they do require correction of this astigmatism, because the visual acuity, if you measure, it can be close to 6.6, but the crispness of vision is not there if the astigmatism is not fully corrected. And that is true if you don't correct the astigmatism. And that's why it's very important to think about the cylinder as well as sphere. And another point I would like to mention here is that when you're starting your practice of toric IOL, many times you fear that if it's slightly off axis by 1 degree, 2 degree, we have been reading theoretically so much, then it will cause a lot of problems. Little bit of 1 or 2 degrees here and there, it doesn't make much of a difference, and these toric IOLs are very forgiving. Even if you get, when you do a post-op, if you do refraction and then if you get a little bit of cylinder, the eye is such, and the defocus system of the eye is such that the patient does not have much problem and the patient has a crisp vision. So what is most important is that we have to decide first that how much is the cylindrical power, and we correct the corneal cylindrical power, because in any case we are removing the lens. So if there is any issue related to lens related cylindrical power, we don't have to think about that internal astigmatism, we just have to think about the corneal astigmatism. That is one. So an accurate measurement of astigmatism and axis is important. Second thing is you have to mark properly. Marking is important. That should be accurate, because then you will place the IOL over that axis. So the marking is essential, and then of course the placement of IOL. The patient selection, in patient selection you keep all those patients who have regular astigmatism, not irregular one. You can do keratoconus, etc. Some unique cases as well wherein there is no progression, which Dr. Tushar will be discussing with all of us. Conditions wherein we may require a corneal procedure later, something like somebody is having a Fuchs dystrophy or a stromal dystrophy wherein you have to do a corneal procedure. In such cases, we should avoid using toric IOLs. And as I said, toric IOL cylindrical power is based on corneal astigmatism. Scheimpflug imaging is done. Patient evaluation, Dr. Vanashri has already done all these IOL power calculations. I'll just skip that. And I'll just move on. I'm sorry for that. Coming to the marking. So the first thing, as I mentioned, is the marking on the cornea. So how we should do it? We can do it manually, or there are options of digital marking, wherein you don't have to mark, but you get under the microscope, you get the exact axis. Many of us will not be having the digital system. So manual marking is a good way of doing it, and studies have shown that if manual marking is done appropriately, properly, then there is hardly any difference between the manual marking and the digital marking. So the most popular method of marking the cornea is the bubble marker. Here you have a bubble, as you can see. It should be in the center, and then you put some gentian violet over here and then place it over the cornea and mark it. What is essential is that the patient should be upright. The patient should be standing or sitting. Best thing is that if you have a wall, then you ask the patient to stand there opposite wall, so that you can directly see that there is no head tilt, etc. So if the head is right straight, then in that case you can just put a drop of proparacaine, and then you can mark it directly. Asking the patient to stand against a wall is very helpful, because then the patient has a tendency to remain straight. That is the advantage. Another method is that you can directly mark. You ask the patient to look straight ahead, take a marker, and you mark directly the 6 o'clock position. But then 6 o'clock position marking can be done by that as well. Then people have also used pendulum marking, or there are various other methods. On slit lamp, you can mark, you can put the slit beam like that, and then you can mark 0180, you can mark 12 o'clock, 6 o'clock. So all these things can be done manually very reasonably accurately. And these are all reference marking. And once the reference marking has been done, this is done because in the sitting or standing position, because once the patient lies down, there is an element of cyclotorsion. And nobody can predict. We have published an article on cyclotortion, and we found out that cyclotorsion can be clockwise, it can be anti-clockwise, both ways. It can be 7 degrees, it can be 10 degrees, it can be 14 degrees. So the maximum that we got was 14 degrees in our study. So because of that, we have to mark it in a sitting position, and then once the patient lies down, we have, based on the 0180 and 6 o'clock position, we can mark the axis exactly. And once the axis is marked, you align the IOL along the axis, and this is how it looks like. You can see the mark here, you can see the mark of the IOL and the mark on the cornea. So there are various situations, there can be various positions of axis wherein you can place, and as you can see here, once again, it's a little faint, but the mark is here, and this is the dots on the lens. Sometimes you have a scar in the peripheral cornea, and sometimes you have a scar in the peripheral cornea. If you have a scar in the central cornea, it is not advisable to put a toric IOL, because it will cause irregular astigmatism. But sometimes a scar in the peripheral cornea can have an astigmatism which can be measured in the two axes, in the two meridia, and there you can place the toric IOL. Another scenario which I would just like to add here is cases of megalocornea, wherein you have a large bag. In such a case, wherein if you put the IOL in the bag, it will rotate. And this we learned from a case which was referred to us, a case of megalocornea, wherein the IOL rotated, and then again the surgeon re-rotated it in the same position, and again it rotated. Then the patient was referred to us, and then he found out that it has a megalocornea. And from there we learned, and then what to do. And then in such cases, the best thing is to put the IOL in the bag and do a reverse optic capture along the axis. So as you can see here in this case, the IOL has been put in the bag. Viscoelastic you should remove from the front and from behind. And because removal of viscoelastic from behind is very essential, otherwise there is risk of post-op rotation. And once you have removed that, you can inject some viscoelastic to maintain the chamber, and then go behind the IOL and bring it anteriorly once you have rotated it along the axis, and do a reverse optic capture. So in cases of megalocornea, which you get very infrequently, but yes, we can do that and have a stable IOL in position. Other method is markless alignment, that is digital method, that is we have Callisto eye in the Zeiss microscope, we have Varion digital marker, we have ORA, that is opti-wave refractive analysis. So in Zeiss microscope, I don't have any financial interest, they have the Callisto system, wherein you get this, this is the reference marking 0180 degree, so you can place the incision along that axis, and then this is the axis along which you have to place the IOL, you have to align the IOL. I'll just show you a small video clip. So this is the reference marking. So you have made an incision, you make the incision along this reference marking, and this is the central line, the blue line is the line along which you have to align the IOL axis. So once you have implanted the IOL in the bag, you remove the viscoelastic from the front from the behind, and while removing the viscoelastic, if you are using a coaxial, you can rotate the IOL, or you can bring the IOL close to the axis before removing the viscoelastic, and then remove the viscoelastic. So all these things can be done. You can modify your technique the way you want. Finally, what you want is the IOL, this mark to be aligned exactly along the central blue line. That is what we want. Varion reference unit is there with the Alcon system, and they also, it basically measures the axis, and then based on the scleral blood vessels and the uveal structure, it gives you the idea about the axis. And this is how it looks like when you place the IOL along the axis. This is how you have to align it. Then ORA system is again, that is OptiWave refractive analysis, is again a digital method of aligning the IOL. And in that, once you have removed the cortex and nucleus, then you inject viscoelastic, form the chamber tight, and then use the ORA system to calculate the exact power of sphere and cylinder and the axis, and then you place it accordingly. And once you have placed it, what you want to see is, once you have put the IOL in position, aligned it along the axis, then you again do ORA, and then if you get NRR, that is no rotation recommended, then you don't have to do any rotation. Otherwise, it will give you an idea that, see, you have to rotate this much counterclockwise or rotate this much clockwise. So that is again a method of doing it if you have this ORA system. And but once again, having said that, these are all expensive equipments, and if you don't have these equipments, it doesn't make much of a difference, because studies have shown that appropriately done manual marking is comparable to all these digital marking methods. And as Vanashri was mentioning, the current generation hydrophobic IOLs, they have that shrink wrap effect. And if you have a good capsular axis which is just covering the IOL optic margin, it will have a nice shrink wrap effect. And if you have removed the viscoelastic from behind the IOL, there is no chance of any post-op rotation. And if you have any such thing, Dr. Harshal will be mentioning about all those surprises that we can get after implanting a toric IOL in its position. So thank you very much. I will thank Dr. Vanashri once again for the opportunity.
Thank you so much, sir, for the wonderful insights and tips into the surgically managing placement of the toric IOL. So just one question I would like to ask. Sometimes when we are placing the toric IOL along the axis, the lens kind of doesn't sit in the place and tries to go a little away from the axis that has been marked. So any tips to the new surgeons how to align in that case? Like, should we re-rotate the new?
The best thing is that don't put it, when you are rotating it, just keep it a few degrees before the exact axis.
Right, sir.
Because when you are hydrating, what happens that sometimes it has a tendency to rotate little bit. And if it rotates little bit, it will come into bang into axis. If you have put it bang on axis, it will rotate. And then you cannot rotate opposite side. You have to rotate it clockwise only.
Right, sir.
So it is always better to place it in the axis, maybe just about 5 degrees before the intended axis, so that when you are hydrating, if it rotates little bit, it can come in position. Even if it doesn't rotate, with the simple BSS cannula, you can simply put some BSS, and with the cannula you can bring it in position. So that is important when you are placing the IOL, particularly not for the beginners, even for everyone, for experienced people also.
Right, sir.